Good evening, everyone, and thank you for joining us this evening. My name is Leslie Fontenot. I'm the VP Managing Director for Black Health Matters. You are in for a treat. We're so excited. You will be empowered after hearing tonight's speakers this evening. So I'd like to say, first of all, thank you to our hosts, the National Coalition of 100 Black Women of the Pennsylvania chapter, and also our sponsor, ASI, and to everyone who is viewing tonight's program from wherever you are, whether you're in Pennsylvania or the rest of the country. Black Health Matters is an 11-year-old national multimedia communications company dedicated to eliminating health disparities and improving health literacy. We reach more than 1 million people annually through our blackhealthmatters.com website, our social media pages, video content, and in person through our nationally recognized Black Health Matters Health Summit and Expo. Also at local community health events and webinars like the one you see here that you're going to be entertained by here today. You can learn more about us by visiting blackhealthmatters.com. Our sponsor for this webinar is ASI. ASI is a human healthcare company who has worked in partnership with advocacy groups Share and Force to educate women about endometrial cancer, and also Icana, who we have here tonight, through a 3-year initiative titled Spot Her. Spot Her is an initiative to help end the silence around endometrial cancer. And together we can help empower people across generations and cultures to spot the potential signs early, speak up, and take action. And so for tonight's program, our order of the agenda will be that we'll hear from the first Vice President of the Pennsylvania chapter of National Coalition of 100 Black Women. And then we'll hear from our speakers, Dr. Robin Wilson Smith, as well as Heide Spence, who is our patient advocate from Icana. With that, I will turn the virtual mic over to Ms. Jennifer Powell-Folks. Thank you.
Thank you, Leslie. Welcome to everyone. My name is Jennifer Powell-Folks. I am the first Vice President of one of the founding chapters of the National Coalition of 100 Black Women, Pennsylvania chapter, founded over 40 years ago. On behalf of our incredible President, Nyesha Chapman, and our astounding leadership, as well as our board, I welcome you to this incredible webinar, sponsored and led by the Black Health Matters organization. We are honored by partnering with this great organization. It is life-altering and will be life-affirming information. And as an individual who suffers from these types of challenges and have lost family members from endometrial challenges, I think we all should sit forward, listen, take in the information, because it is not always widely offered nor shared with women of color. As our illustrious speakers will share, it is a topic Black women have suffered from in silence on too many times. And we are so grateful for their support over the years, and we will continue to be partners and look forward to being partners with them. I will not drag out this long drawn speech of mine, so I will gladly turn it over to the charge of back to Leslie and the speakers. We are so very blessed to have their knowledge, experience, and look forward to what they will share with us today and in the future. Thank you so much. So pay attention, ladies. You're in for an awesome webinar. Thank you.
And thank you so much, Jennifer. And so you might wonder, why are we talking about endometrial cancer? You know, there's a deadly disparity in this area. The numbers are truly shocking. Black women are nearly twice as likely to die of endometrial cancer as white women, even though the disease is actually slightly more common in white women than in Black women. The number of cases of endometrial cancer are still on the rise, with the greatest increase among Black women. And to be honest with you, what you'll find out tonight is that early detection can really help you. This is one disease where early detection can help. So the learning objectives for this evening are so that you can understand what is endometrial cancer, why is it so prevalent among people of color, especially Black women, the types of gynecologic cancer, as well as hearing from our patient ambassador, Heide Spence. So with that, I'm going to start out by sharing the biographies and the background for the two speakers that you're going to hear tonight. First, Heide Spence. Heide Renee Spence is a survivor of endometrial cancer and active member of ICANA. ICANA is the Endometrial Cancer Action Network for African Americans. Heide was recently interviewed by Good Morning America, and her article entitled "My Health Has to Come First" was featured on icanawomen.org. Heide is passionate about educating women on this disease, focusing on overall health and self-care. She is currently attending the University of Arizona, studying business organizational management. Heide resides in New Jersey, where she enjoys spending time with her son, daughter, and extended family. And at this time, I will turn the virtual mic over to Heide Spence. Thank you.
Thank you very much. So I am grateful to share my story, and that the leaders of ICANA reached out and asked me to share my story with everyone tonight, because I think it's important. It's very important. We always hear about breast cancer, and in my lifetime, I've heard about other cancers, but endometrial cancer does not get the same recognition, and it is just as important. So with that, let me see. As a single mom of two, my story started when I was really young. I started my menstrual cycle at 10, and it was always irregular. Went through a lot of changes, and it was very sporadic. And, having a menstrual cycle is not necessarily the thing that we all are excited about as women to have. So as a young woman, I didn't take it serious when I didn't get my menstrual cycle. I didn't think anything was wrong. I didn't think it was anything to worry about, until it became that I got my menstrual cycle, and it was very heavy and it was very painful. And I went to different doctors. Of course, as a young person, changing jobs, which also came with changing medical insurance providers, and what I had access to made me change doctors often, or avoid going to the doctor. So I could go months. I got to a place where I went years without having a cycle. And when it would come on, it would be very heavy. It would be very painful. I went through having ablations to try to stop it. I had gone through taking medication to try to help me regulate the period. It was a challenging time as a single mom, raising little kids and just trying to work and show up. And so I found myself, when I wasn't having trouble with bleeding, which meant that my menstrual cycle was not happening, I lived life as usual. It was when my menstrual cycle was heavy or I was having severe pain that I tried to make time, but it wasn't always the top importance, because I was worried about being able to show up for my family, not losing my job because I was missing time. But I was having heavy periods. When I think the last time I had an ablation, the bleeding was so heavy. I can remember my grandmother saying, like, this has to stop. The doctor has to do something about it. We had an ablation and I went back to work and things were fine for a few months. And then I went to work and I would carry a night, like an overnight bag of clothes with me because I could get from my house to work and my clothes would be a mess from my menstrual cycle being so heavy. Um, and so then was a time I was at a place and time where getting help and finding a resolve was very important to me. So I took the time to, go to see doctors and say, like, something has to change. This can't be right. And when I didn't like what the doctor said and I trusted, I felt like something was seriously wrong, I changed doctors again and got another opinion. And that time, the doctor tried a few different things. And I mean, I'm not, it's not all on the doctor, right? Because when things were great for me in a sense of I wasn't having heavy periods or in pain, I wasn't being consistent either, right, with following through. Um, so this one time I went to the doctor and I was like, this has to stop. Like, I can't, I'm in a job that I really love. I can't keep missing work. Something has to give. And that doctor said, let's do a biopsy. Um, and I remember she called in 2017 to tell me, she said, are you at home? Are you in a place we can talk? And I was like driving in the car. And I said, yeah, we can talk. And she said, it sounds like you're driving. I said, yeah, I'm good, but we can talk. And she was like, well, I need you to pull over. I was like, okay. So I pulled over and she said, your biopsy came back and says it's cancer. So we need you to come in. And I was like, okay. That was Thursday. I went into the office on Monday and she was like, okay, we've got you scheduled for surgery. We're going to give you a hysterectomy. And I was like, what? It was 6 years ago. I wasn't prepared for that. I wasn't ready. I was like, I'm not married. There were so many things that went through my head. Like, there's so many other options there has to be, right? And so I was like, I have to think about it. And she was like, well, you can't think hard. We have to act fast. You can't think long. We have to act fast. And I went home and, I talked to people that I trusted about it. And I felt like I needed a second opinion. And luckily for me, when I started to call other doctors in the area, one of the doctors that I came across to get a second opinion was a doctor I was familiar with and I trusted very much. She had delivered my daughter when I had her. And then she had gone back to school and expanded her knowledge. And so she was a gynecological oncologist. So I asked for an appointment with her and I went back to the doctor who told me, and I said, I'm going to get a second opinion. And she said, okay, well, I'm going to have to put you on medication because this is serious and I need you to take this serious. And I was like, okay. So I started taking medication. And I remember when I finally got to the appointment to meet with the doctor who you guys have the pleasure of hearing from tonight, Dr. Robin Wilson Smith. I was like, I don't know what's going on. This all sounds like a lot, but this is what they said. I had my records sent over to you. I wanted a second opinion. And I trust what you say because I'm in a space that, like, I'm not married. I have my 2 kids, but I don't know where life's going. What is going on? And she was like, if you want to have kids, I suggest you start now if you want more kids. If not, it's early. And that's something that not always happens. And I recommend that we have a hysterectomy. And I'll never forget, that was in January. And she said, okay, they're going to they'll put you on the schedule. And my mom was like, okay, if this is what we're doing. And I was talking to like my close friends. They were like, you have to be here for the family that you have now. You can't worry about the future. And so we did it. And I'm an only child. So my mom was like really worried, right? And she's talking to Dr. Olson, so take care of my baby, right? Mind you, I'm a grown woman with my own babies. And so 5 years ago, Dr. Wilson Smith gave me a hysterectomy, and life has been different for me for sure. And it was definitely a new look at life for me, because I recognize, in looking back, that I put me last, and I put me last telling myself that I was making sure I was aware around to take care of my kids, or saving my time to my vacation time to make sure I had it available for my kids. However, the reality is I needed to make time to take care of me and follow through with the doctor. So if I can leave anything with you and ask you to remember anything from my story, um, would be trust your body. If you see a doctor and you don't feel that they are listening to you, I would say seek another doctor, um, and continue to seek another doctor until you feel that someone's hearing you. Don't let it be um, unanswered. Don't let it be pushed to the side. Don't allow situation or circumstance to dictate how you show up to take care of your body and listen to your body, because it's important. If you're having heavy periods, um, if you are going through pain in your pelvic area, if you're having changes and something just doesn't feel right, see a doctor and listen to the doctor. I know it can be a lot, juggling schedules, family, work, health issues, but it's important to take care of yourself. I'm grateful that post hysterectomy, um, and just looking for people to help me digest, um, being on the other side of a hysterectomy at 37. Um, I had joined different groups on social media. That's a wonderful tool that we have available to us. Um, and I met the women of Icana. Um, and through working with the women of Icana, I've been able to support other women who are going through endometrial cancer, determining what's the best resolution for them, being able to listen to them, you know, sympathize with them, share my story with them. Something I would encourage you to do if you are experiencing symptoms of endometriosis or PCOS, polycystic ovarian syndrome, or fibroids, is to get a journal, right? Or use your smartphone notes to document what's happening, because it all happens very fast. It happens sporadic. And when you go to the doctor, the best way for the doctor to help you is to be able to give them clear information. And it's hard to remember off of the top of your head. So if you just jot it down, like, yeah, my period was 2 days, or my period was 3 days, definitely just jotting down the things that are happening along the way will help the doctors help you and make it better. So I think this is a great resource, and I'm grateful for all the people who are tuned in tonight to learn something and just looking out. And I think this is important to share often, share with your friends. I share on social media. It's like my second birthday. We talk about it. When I got a new chapter on life, February 16th, 2018. So I think if you don't remember anything, definitely remember to take care of yourself, journal what's happening. And if you're unhappy with what the doctor is telling you, seek a new doctor, because you'll eventually find the right doctor that knows what's going on or willing to go the journey with you to figure it out and resolve it. So trust what your body is telling you. And with that, I think we can turn it over to, I'll turn it back over to Leslie.
Oh, thank you so much. My heart is so warm. What words of wisdom you provided to all of us. And thank you so much for sharing your inspiring story and telling us to trust our bodies. which,
Absolutely.
and speaking up for yourself, it is so important.
It
At
is.
this point, what I'd like to do is introduce our speaker, Dr. Robin Wilson Smith. Dr. Wilson Smith stands at the forefront as the medical director of Gynecologic Oncology Services at the Sidney Kimmel Cancer Center, Washington Township. Hailing from South Jersey, Dr. Wilson Smith is a specialist in diagnosing and treating cancers of the female reproductive system, employing the latest therapeutic approaches. As of 2023, she celebrated her remarkable achievement of executing over 1,300 Da Vinci robotic surgical procedures. Guiding her medical practice is a profound principle to care for patients the way she would want her own family to be cared for. Educationally, Dr. Wilson Smith pursued her Bachelor's of Arts in African American History from Rutgers University and her Bachelor of Science in Biology from Rowan College. She earned her medical degree from the University of Medicine and Dentistry School of Osteopathic Medicine. Her professional journey continued with her residency and fellowship at Cooper University Hospital, MD Anderson Cancer Center. Before embracing her leadership position at Jefferson Health for the past 5 years, she dedicated 16 years of practice there. She holds board certification from the American Osteopathic Board of Obstetrics and Gynecology in both OBGYN and gynecologic oncology. That's a tongue twister, right? Away from the hospital, Dr. Wilson Smith, a devoted mother of 4, including triplets, oh my gosh, enjoys camping adventures with her family. She harbors keen interest in robotics, diet, and nutrition. And furthermore, she is a proud member of Delta Sigma Theta Sorority Incorporated, a nonprofit championing community service. And with that, thank you so much for being here, Dr. Wilson Smith. We can't wait to hear from you. Thank you.
You're
And
welcome. It's a
also, I would
pleasure
like
to be here.
one other thing I'd like to ask everyone, if you have questions at this time, please feel free to include them in the chat and we will address them at the end of the presentation. Thank you.
It's a pleasure to be here. I'm going to share my screen. Are you able to see my presenter screen?
Yes, it's lovely.
Okay, awesome. So before we dive in, I just want to say I was truly touched by hearing Heidi's story all over again. Just say that it wasn't planned that both of us would be in this space at this time. And so it's pretty amazing that it happened this way. And then also, I'm very, very proud of her that she has found purpose in her journey and that she didn't just decide to go through this alone, but that she's helping other women as she is celebrating her survivorship. So thank you so much, Heidi. I really enjoyed hearing your story over again. Before we dive in, I'd like to thank the National Coalition of 100 Black Women, Black Health Matters, Isai and Akana for inviting me to speak today. Their work is something that I deeply respect, and it's an honor to have been asked to contribute to today's discussion along with Heidi. So what is a gynecologic oncologist? That's what I do. So I just want to define what that is because there's many different areas of OBGYN. There's regular OBGYN where you get your pap smears and your screening and things like that. There is maternal fetal medicine, reproductive health, but what I focus on is gynecologic oncology. And so I basically care for women who have ovarian cancer, uterine cancer, cervical, vulvar, vaginal cancer, cancers that arise from pregnancies. They're called gestational trophoblastic disease. We give chemotherapy and we do surgery. So we are the only surgical specialty in the United States that does both surgery and we give chemotherapy. So we're a little unique in that sense. So a little bit about me. Like all of you, I wear many hats. I'm a daughter, sister, wife, mom, friend, doctor. I consider myself a daughter of South Jersey. I was born here. I never left. I went to high school here, college in New Jersey, medical school, and I currently practice at Jefferson Health, New Jersey. So I'm a proud South Jersey member. So the agenda today, I'm going to go over what is endometrial cancer. I'm going to focus on, why should we focus on Black women? Why are we teasing Black women out of this situation, and why is it important? What are the risk factors associated with endometrial cancer? What are the symptoms? How is it diagnosed? And what are the treatment options? Also, why is it important to follow up? And are there any prevention strategies? So we'll go over what is endometrial cancer. However, in order to do this, I want to review the normal anatomy. I'm sure we're probably all familiar with the anatomy, but I just want to review it briefly. So you'll see here, this is the uterus. These are the fallopian tubes. These are the ovaries here. I'm turning to the side because my screen's here, I'm sorry. And this is the cervix, and this is the vagina. So think of the endometrium like the wallpaper inside of our uterus. So that's when things go wrong with that wallpaper that's located inside of our uterus. Before we go through menopause, this wallpaper is stimulated by various hormones and shed every month. So it's very thin, and then it goes and gets thick, and then it sheds. We have our period, and we repeat this cycle every month because our body is preparing for pregnancies. So I like to think about the uterus like a light bulb. So the silver part of the light bulb here is actually the cervix, and this upper part of the light bulb is the actual uterus. So whenever you're getting your pap smears, we're only checking the silver part of the light bulb. This is the only part we can visualize in the vagina when we put the speculum in. So where the filaments are, that's where endometrial cancer arises, where cervical cancer arises here. And it's important to know that when you're getting your pap smears, it's not screening for endometrial cancer. As a matter of fact, we don't have a good screening test for endometrial cancer. Your screening is abnormal bleeding. That's your heads up that something's not right. And when I say abnormal bleeding, I mean, even if you just spot one time in your postmenopausal, if it's red, rust color, brown, burgundy, bright red, anywhere in the spectrum of red, you need to be evaluated. Even if it was just one time, you need to be evaluated. And as Heidi mentioned, if you're having abnormal cycles and you're premenopausal, you still need to be evaluated, especially if you have risk factors. So it's important that we take a look at that. Now, we do have screening tests for patients that are at high risk for cancer. They have some type of genetic abnormality, but we don't have a routine screening test for the general population. So let's take a little closer look at the lining of the uterus to really understand what's going on at that wallpaper. So this was, for some reason, the reason I became a gynecologic oncologist, or even a GYN. For some reason, this diagram really did a lot for me and made me want to do OBGYN for some reason. But, it's pretty amazing. This is the ovary here at the top. This is what the ovary is doing during your cycle. This is what our hormones are doing during our cycle from the pituitary gland in our head and the ovary. And then this down here is what the lining of the uterus is doing as a result of all of this whole process. So our pituitary gland releases hormones, FSH and LH, and it tells our ovaries to release estrogen and progesterone at different times of the cycle. And estrogen and progesterone, I like to think of them as like yin and yang. They work together, they balance each other. They both are very needed in a healthy menstrual cycle and for a woman to be healthy. So what happens is, as a result of our pituitary gland releasing these hormones, our ovaries starts to develop a cyst on the ovary. This is also important because I have a lot of patients that will come and say, I had an ultrasound and I have a cyst on my ovary. Well, every woman should have a cyst on their ovary pretty much every month, because that's how we ovulate. And if you catch it at a certain time during the cycle, you'll see that cyst. Now, we do have some cysts that are abnormal and that aren't supposed to be there and they look abnormal, but for the most part, if you're a healthy female, you're going to develop a cyst on the ovary. That cyst on the ovary helps to regulate these hormones. And so what you see is at the lining of the uterus, as estrogen is being released, the lining is getting thicker. So I like to think of the lining of the uterus like a lawn. So if you think about fertilizer on the lawn, the grass starts to grow. And then progesterone is released once the ovulation happens, and that corpus luteum cyst on the ovary releases that progesterone. You can see that spike right here, and it tells the lining of the uterus, okay, stop growing. We're going to wait. We're going to see if she gets pregnant and an embryo implants and sets up camp on our nice plush lawn. Okay. If that doesn't happen, this corpus luteum cyst goes away, which means progesterone goes away, and you see it drop here. And that drop in progesterone acts like a lawnmower. So then you have your menses. And we do this every single month. So women who have PCOS, where this ovarian tissue is not working properly, they can have problems with this, and it can make that lining get out of control if estrogen is not balanced with the progesterone. So this diagram is very important, and it's how we function. If you are postmenopausal, you should have turf. You should never have thick grass. Your lining should be thin. It should never grow because you're not doing this whole process anymore. Your ovaries are not releasing these hormones. So if you see a woman with a thickened lining or she's shedding and bleeding, something's not right. She's getting estrogen from someplace else. And that takes us to the next slide. So obesity and being over our ideal body weight is what getting some feedback. Being over our ideal body weight is what can increase estrogen in our bodies, because our adipose tissue, our fatty tissue, can make estrogen. So the more of it that we have, the more it feeds that lining of the uterus. And the problem with it, if your ovaries are no longer making progesterone or they don't make it properly, then what happens is that that lining just continues to grow and there's nothing to balance it. Also, estrogen replacement therapy. If you're on estrogen replacement therapy and you are not balanced with progesterone and you have a uterus, if you don't have a uterus, it's not necessary. But if you have a uterus, you need to be balanced with progesterone, because you can create endometrial cancer by just having estrogen without the progesterone. Also, tamoxifen. What it does, it helps with breast cancer, down regulates estrogen at the breast. However, it can up-regulate estrogen at the lining of the uterus and cause the opposite at the uterus. And women can develop endometrial cancer. Also, if you started your period really, really early and then you stopped your periods really, really late, you have a long time where you're exposed to estrogen, that increases your risk as well. As mentioned, PCOS, if you've never had pregnancies, and also estrogen secreting tumors. So there are tumors like granulosa cell tumors that can happen on the ovary, and they release estrogen. So these are all the other ways that you can develop excessive estrogen. So statistics, 66,000 new cases of endometrial cancer a year. And this has gone up a lot, even from when I started fellowship many, many years ago. We were not at that number, but as we get heavier as a nation, this number is increasing. Also, 13,000 women every year die from this disease. The average age is 60, and we have about 600,000 survivors of endometrial cancer in the United States. So why should we focus on Black women? Like, why is it so important to talk about this? Leslie kind of alluded to some of this in the beginning, but we have a higher mortality rate. American Cancer Society noted that the death rate for endometrial cancer is 55% higher for Black women than white women. Also, for some reason, we tend to present at more advanced stages of diagnosis. And these more advanced stages are difficult to treat, and they can contribute to our higher mortality rate. Also, we're more likely to have aggressive tumors like serous tumors and clear cell and carcinosarcomas. So endometrioid is the most common tumor, and these other tumors, I always call them the bad boys, they are higher chances of metastasis. So also biological factors. There's emerging research right now that's indicating that certain biologic genetic factors may contribute to differences in endometrial outcomes. And for example, differences in tumor biology and genetics between Black women and other women of other races may influence the behavior of cancer and response to treatment. So I always say you can have two women, both of them same exact stage, and they can have endometrial cancer, and it can be what we call a FIGO grade 1, and it's early, and one will do great. And then the other one will go on to have metastatic disease. And we're learning now that it's not just about what the tumor looks like or the name of it, it's about the biology of it and how it behaves. So a good example is I have 4 children, they're all Smith kids. However, they do not all behave the same. I have some that are very, very mild-mannered, some that are more outgoing. So all cancers, even if they're the same type, same stage, may not behave the same. So now we're doing more personalized medicine to help treat patients. Also, socioeconomic and healthcare access factors can also be an issue for Black women. Lower rates of access, differences in healthcare quality, socioeconomic disparities are also contributors to these outcomes. In terms of survival rate, the 5-year survival rate for endometrial cancer in Black women is lower compared to white women. And this disparity is evident despite the patient's age, what cancer stage they presented at, or the grade of their tumor. Also, importantly, at least 2 studies so far have reported that Black women are less likely to receive care in line with the guidelines, which is in turn associated with higher odds of advanced stage of disease diagnosis, meaning that if you present, let's say, to your provider and you have a certain grade, certain stage, you may not get the same care as the next person. And, you know, they're delving into this more to try to figure out why is this the case. And I'll show you some ways that you can try to prevent that from happening for yourself. We need to focus on early detection. We need to focus on effective treatment and address these disparities in African-American women. So we have historically classified tumor types as type 1 and type 2 of the lining of the uterus. Type 1 is the more mild type that, you know, usually you can do a hysterectomy. Most of the time they're cured with that hysterectomy and they don't really need anything else. Then you have type 2 tumors, which are a lot more aggressive. I mentioned those are like the serous, the clear cells, carcinosarcomas. Those will usually need chemotherapy afterwards, radiation. They can present at higher stages and harder to cure. Now, of course, African-American women, Black women, we more commonly get these type 2 tumors. And, you know, we're trying to answer those reasons as well. So this does not pertain to premenopausal women, this what I'm getting ready to say, because the lining of the uterus can fluctuate. Because remember, I showed you that graph where your lining can be thick and then thin and then thick and then thin. This is more for postmenopausal women. So if you can see here, I'm going to show here what we call the sagittal view. This is the back of the patient, the front. This is the bladder, the uterus, and then this is the rectum, and this is your spine. Okay, so this lining here, when you have an ultrasound, this is what's being measured when they're trying to determine if this lining is thick. And our current guidelines say that if you have abnormal bleeding and your lining is less than 4 to 5 millimeters, the chances of you having cancer are very, 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 very small, and you can be managed conservatively. This is where we fail and underperform for Black women. Because type 2 tumors, as I mentioned on the last slide, we're more common to have those tumors. And type 2 tumors can have a normal endometrial stripe. So you can get an ultrasound and you can have a normal stripe, but you can still have endometrial cancer. And so, you know, the question is this also, and along with everything else, contributing to the late diagnosis of these more aggressive tumors? And you'll see here, this is a probe, the ultrasound that's placed into the vagina, and where we can see the lining of the uterus, and then they'll also put the probe on the belly, but the transvaginal one is the one that's the most important. And this is a real life picture. And you can see the thin lining here that this particular person has. This is the bladder. And we're measuring this lining here. So this is a recent trial actually done by Dr. Kemi Dahl, who is the president of ECANA, who Heidi represents, the Endometrial Cancer Action Network for African Americans. And she's done a great deal of work looking into the disparities for African American women with endometrial cancer. And she published a paper in 2021. And the paper was called Estimated Performance of Transvaginal Ultrasound, the ultrasound I just showed you, for evaluation of bleeding after menopause in Black and white women in the United States. And what she found was that it missed this screening test that we use and that we say is the standard of care that all your doctors are using. It's missing almost 5 times more cases of endometrial cancer among Black women versus white women.
Jesus.
So this is problematic. And, you know, this could be because of our fibroids. If we have fibroids, this could be because of the fact that we have those non-endometrioid or type 2 tumors as well. So she is working very hard and diligently to get these guidelines changed and to change the threshold for Black women so that Black women are not being missed in terms of early diagnosis. And this is also why it is really, really, really important for us to enroll in clinical trials. I have to put a plug in for this because we don't always enroll in clinical trials, whether it's not accessible to us or offered to us, or we don't feel comfortable or we don't trust. But, you know, for whatever reason, we're not getting into these trials so that these things can be picked up. And so it's important, if you have access to clinical trials, ask about them, enroll in them, and get involved so that you can make a difference as well for the people who come behind you. I just put this in here as like a little commercial break. Self-care is about you, about giving the world the best of you instead of what's left of you. So what are the risk factors? So the 2 most important ones that I'm going to talk about are obesity and diabetes. Family history can play a role, of course. You can have to be genetically predisposed. We have lower rates of getting screened for genetic problems when they arise. Polycystic ovarian syndrome, although the rate is the same with African Americans and non-African Americans, this increases your rate. We talked about hormone replacement therapy and tamoxifen increasing your rate. But diabetes and obesity is where I think there's this disparity. So 57% of African American women are classified as obese compared to 38% of all US women. So because we have that excess adipose tissue, that also puts us at risk for endometrial cancer. As you can see, I'm stacking up all the things that we have increased risk, that put us at increased risk for these tumors. And then as we age, that gap gets even wider. Diabetes, it's a result of insulin resistance, hormone imbalance, obesity, and common lifestyle factors. And 14% of African American adults have diabetes, but over the age of 55, 25% of Black women have diabetes. When you look at the general population, it's at 10%. So those 2 are huge risk factors for us right there that are that can be modified, which we will talk about later. So when should you consider genetic testing? Since I mentioned it, if you have a personal history of certain types of cancer at a young age, if you're being diagnosed with more than one cancer, if you have multiple family members with cancer, especially if they're diagnosed at a really young age, family history of the same type of cancer or related cancers, if there's a male in the family that had breast cancer, family member who has cancer in both breast, or they have both breast and ovarian cancer, certain ethnic groups should be screened. And also when we get the pathology back, we look to see if there's any pathologic indication that we should be sending you for genetic testing. So here's another potential risk factor that's coming out. And I'm sure you guys have been witnessing this all on the news and on billboards. There's lawsuits right now for relaxers as they're thought that they may increase the risk of fibroids, uterine cancer, and breast cancer. There have been studies exploring the potential link between the use of these hair relaxers and increased risk of hormone-related issues, including all the cancers I just mentioned. This is important as, you know, this is used by many of us. Some chemicals in the hair products can be absorbed through the scalp and have estrogen-like properties in the body. So they can cause this estrogen reaction that you're having from, you know, your ovaries. And so, you know, it's important for us to be aware and be on the lookout for the final data on this. So this was brought to us in October of last year. And this was put out by the National Institute of Health, NIH. And basically they said hair straightening chemicals are associated with higher uterine cancer risk. And this was done in a study called the Sister Study. It was 33,000 women that they looked at over an 11-year period. And they found that if you never used a hair straightener, your risk of developing uterine cancer by the age of 70 was 1.64%. But if you used relaxers more than 4 times a year, your risk was 4%. So it more than doubled your risk if you used hair relaxers more than 4 times a year. The problem was they didn't tease out what products, what brands, was it lye, was it no lye? This was just all comers. So the study is still ongoing, and the conclusion has been that we need additional research to confirm and to clarify this link. However, definitely be on the lookout if you can try to minimize, if you do use relaxers, try to minimize if possible to reduce your risk until we know the final answer to this. So this is Dove. Dove, I'm not sure if you guys have heard of the Crown Coalition, but Dove has partnered with quite a few other organizations, and they formed what they call the Crown Coalition. And basically what they do is they advocate for natural hair and being inclusive with regards to the workplace and school and things like that. So there was a poll that they took. I have to change my hair from its natural state to fit in at the office. And 80% of Black women felt that they identified with this sentiment. So this is important to know about the Crown Coalition, and I'll tell you a little bit about them in a second. And the other important part is if you could lose your employment because of your hair, and you know, it kind of pushes you into using these products. You know, is this systemic racism? Can this systemic racism lead to these healthcare disparities? And these are the things that we have to try to answer and think about. So there are many reasons that African-American women straighten their hair, whether it's convenience, style, assimilation. It's a really sensitive topic, I have found. And but I believe that we can all agree that there has been some hair discrimination now and in the past that has been rooted in our hair care practices. And as mentioned, Dove has been on the forefront of hair freedom for women, and have teamed up with all these organizations. So I wanted to show this slide because this is a real thing that's happening to people. These are recent events. There are meteorologists that are being fired because they show up with their hair in its natural state. This news anchor, she was also fired because she showed up with her hair in its natural state. This young man here, he's from Buena, which is like 30 minutes from here in New Jersey. And he showed up, he wrestled the whole match at his school, and he's a high school student. And then the final match, the ref came out and said, if he doesn't cut his locks off, he has to forfeit the match and his team loses. And so they cut this young man's hair off of his head as people watched, ongoers watched, and he won the match. But you could see, if you ever get a chance to look up the video, he looks so defeated, even though he won. But he had to lose his locks because of discrimination. And then here, this young man at the bottom, Mr. Arnold, he was unable to graduate from high school in Texas because he had locks in his hair. And instead, he got to walk on the red carpet at the Oscars because they wouldn't allow him to graduate. So I'm sure you could see how this might all tie together in terms of systemic racism, if this turns out to be a real thing, and forcing hair care practices that may be harmful mentally and physically to Black bodies. So Crown Act stands for Creating a Respectful and Open World for Natural Hair. And this is the crownact.com. This is the website. If you get a chance, you can go on here and you can sign the petition. As of 2023, there are currently 24 states that have now passed this law, the Crown Act law, that forbids discrimination based on hair texture and hairstyles, including but not limited to locks, cornrows, twists, braids, bantu knots, afros. So there's a petition on there. I've signed it myself. If you get a chance, it would be great to sign it. Should say 24 states, but as of when I printed this, it was 24 states. But I think interestingly, you can see Pennsylvania, the last time I looked, had not passed the Crown Act yet. It's filed, and hopefully, all of our areas on the East Coast will be soon. But right now, it's not. July of 2019, California was the first to sign the Crown Act. 2019, July, also following them was New York, and New Jersey was third after the incident with the young man, Andrew Johnson in Buena High School, that prompted this to get expedited. And he was instrumental in getting this passed in New Jersey. And then in the last couple of years, the military, you can see this is 2021, now has expanded their grooming practices for their soldiers, and it now offers more inclusivity and racial diversity with hair and skin types. I think it's important that the military should represent and look like the people that they serve. And now they allow short hairstyles, they allow cornrows, they allow locks. So they are also coming on board with the Crown Act as well. You carry so much love in your heart, give some to yourself. So what about symptoms? I always think of symptoms like an engine check light. When your car engine light comes on, you take your car to the mechanic. If you have something that's happening with your body, that's your engine light going off, telling you something's not right. So if you are having abnormal bleeding, unusual vaginal discharge, pelvic pain, discomfort, pain with intercourse, enlarged uterus or mass, you need to get seen by your gynecologist. Bleeding has many, many, many different causes. It doesn't mean that it's cancer, but I always say, especially in a postmenopausal woman, it's endometrial cancer in my mind until proven otherwise, which means I need to sample and make sure that it's not, but most of the time it's not. It can be a polyp, it could be a thin lining, it could be many, many other things. Also, you can have other symptoms that are not related to your gynecologic tract. You can have chronic or severe fatigue. You can have weight loss, weight gain, pain. Your symptoms can be really, really vague. And many symptoms are really easy for a very busy woman to ignore. So we just have to make sure that we check in with ourselves. So how is it diagnosed? So we usually start with an exam. And I think this is really important. A lot of times we're just doing a vaginal exam where we put the fingers in the vagina, hand on top, and we feel for the uterus, okay? But there's this whole space back here that we're not feeling. So a lot of times, especially if there's something wrong, we'll do what we call a rectovaginal exam. And that's where one finger goes into the rectum here, one's in the vagina, and you can see it gives you access to this whole space here. So I just wanted to say that because I know a lot of times my patients will come and like, oh, no one's ever done this to me before. And I get it, it's very intrusive, but it's necessary to help us to make an accurate diagnosis and to evaluate you properly. And then there's sampling of the lining of the uterus. There's two ways to do this. We can do a DNC where we take you to the operating room, give you a little bit of anesthesia, and we go inside of the uterus with this large spoon here, and we get a sample. The other way is in the office where we take a small straw, go up into the uterus where that lining is, where the wallpaper is, and get a sample and send it. If you know you're going to get an endometrial biopsy in the office, as long as you don't have any contraindications, it's good to take some Aleve, Advil, ibuprofen, something, just so that it's not so painful, because it is pretty cramping. And then how to make the best of your exam when you go to your doctor. Schedule it first appointment of the day if you can, or right after lunch, because sometimes we get backed up, things happen. So I would say definitely, if you can, try to pick those spots. Write down focused questions. Don't stress about Don't stress about shaving. If you never usually shave, don't shave for your visit. I promise you, we don't remember at the end of the day. If that's not your normal grooming practice, don't worry. Avoid anything in the vagina for a few days. Empty your bladder so you're comfortable with the exam and so that your provider can get a really good feel of what's going on. Ask about sexual health and call for your results. If you don't see your results in your portal, we're electronic now, then call. Say, I don't see it. I want to know if I can speak to someone regarding my results. And then this is how we stage. So depending on where the tumor is located, the area of blue is the where the tumor is located. Depending on where it's located, that's how we come up with stages. And that's how one of the pieces to determine how we treat you. So what are the treatment options? This is so important. Remember, I mentioned that many African-American women are not treated with guideline care. Well, if you look here, this is the National Comprehensive Cancer Network guideline. So no matter where you are, whether you're here, California, New York, in the middle of the United States, we all use these guidelines. We all have access to them, and we should be following them as closely as possible. Of course, sometimes we have to veer off, but if we do veer off, you should ask your doctor why, you're veering off. But they should be able to show you these guidelines and show you where your disease is on this guideline and why they're doing what they're doing. So how far have we come with endometrial cancer? Well, now we didn't have any of these options like a few years ago. It's amazing. We're doing minimally invasive surgery. We have systemic treatment now for advanced disease. We're looking at the biology of the tumor. We're doing sentinel nodes instead of taking all your lymph nodes. We're looking at genomics. We are doing immunotherapy and radiation. So we have a lot more options to be able to treat women with these days. And then these are some of the things that we can use to treat you with. And as Heidi mentioned, we do have fertility sparing options. And these are conversations if you are a young woman, depending on your stage, if you're really early, after you have a lengthy discussion with your doctor, going over, if this is appropriate for you, these are definitely options, potential options. And then also, as I want to stress, clinical trials. But the choice of treatment is tailored to each patient. So if you talk to your friend, she might have something completely different than you had, and that's okay. And I just wanted to review robotic surgery really quick. Instead of opening you up and down, we should be doing minimally invasive surgery if it is feasible. Better outcomes, people recover better, they go home, they get back to their families. 90% of my patients, when I do robotic surgery, they go home the same day now. They don't stay overnight. We usually send them home unless there's something going on. And this is the robot, as you can see, that's how it gets docked over the patient. And then you can see this is where I sit here. So I'm not even over top of you. I have an assistant there, but my head is in a console. I can see inside of you in 3D. I can get into spaces that I wouldn't be able to get into necessarily if I was open. And it's just a much, much, much better way of doing surgery for endometrial cancer. Now, we don't use this for cervical cancer, but we do use it for endometrial cancer. And again, I just wanted to show you the guidelines. It says minimally invasive surgery is the preferred approach when technically feasible. Now, I'm saying that for a reason because 2019, of course, we have a study looking at racial and ethnic disparities in hysterectomy route in women likely eligible for minimally invasive surgery. So in this trial, they looked at African-American, Hispanic, and Asian women eligible for minimally invasive surgery, meaning they could have had minimally invasive surgery, and they were more likely than not to have it. They were opened up instead. And so this is a big deal because in these patients that were opened up, they had longer recoveries, they had higher complications, minor and major. And the question is, why? Why are these women not getting minimally invasive surgery? So what about the follow-up? So after you are diagnosed and treated and all is well, you should be seen every 3 to 6 months for about a 5-year period with your provider, just to make sure that you don't have any recurrence, because even though everything's out, even though everything's good, there's always that potential that the cancer can come back. And then We do survivorship. We try to make sure that you are able to empower yourself, to try to reduce your risk. So, for example, you'll see lifestyle, obesity, sexual health, nutrition. This is the cornerstone of doing well after endometrial cancer, is reducing that adipose tissue from any, or any external estrogen stimulation that you might be having. And what about prevention strategies? How can we prevent it? This picture right here just, to me, represents prevention. This is us right now in the United States. I feel sometimes as a doctor, I feel like we're just mopping up the water on the floor, but nobody ever really turns around and turns the sink off, to prevent these things from happening in the first place. And believe it or not, a staggering 30 to 50% of cancers, according to the World Health Organization, are estimated to be preventable. So yes, we're looking for a cure, but imagine the impact that we could get if we actually focused our time as well on prevention. So tobacco use, diet, physical activity, alcohol consumption, obesity, sun exposure and tanning, vaccination, occupation and environmental, infection control. These are all things that we can do to prevent various cancers. Now, don't get me wrong, there's some genetic factors and other issues that are beyond an individual's control. I completely recognize that, but we have this other area where we can try to prevent and do research for more effective treatments. This is what's going to be needed for comprehensive cancer control. We need both areas. So exercise and diet, again, at the cornerstone of prevention in endometrial cancer. So Hippocrates, the father of modern medicine, said, "Let food be thy medicine and medicine be thy food." So we should look at our diet. So this is our standard American diet. And as you can see, 63% of our dietary intake in the United States is processed food. These are the very things that we should be avoiding that are causing a lot of our cancers in this country. Plant food, which is what we're supposed to be eating the most of, you can see it's very small. And then animal food, about 25%. So this is a motto I love. If it came from a plant, eat it. If it's made in a plant, don't. So true healthcare reform starts actually in our kitchen. There was a trial that evaluated these recommendations right here, these 10 recommendations, 380,000 people for 13 years. Those who were able to do just 7 of these recommendations, they had a 34% less risk of dying from all diseases. And if they had a healthy weight, 22% reduced risk of dying. And if they ate a plant-based diet, that gave them a 21% risk reduction from death. And that including just being a healthy weight, physical activity, eating diet rich in fruits and vegetables, limit fast foods and limit processed meat and red meat, limit sugars and refined, limit consumption of sweet drinks, limit alcohol, supplements, breastfeeding moms, breastfeed if you can. And then also after cancer diagnosis, follow up. So your lifestyle matters. Self-exams, educate yourself, be physically active, maintain a healthy weight, don't smoke, eat as many plants as possible, use sunscreen, drink alcohol in moderation, and have regular physical exams. Self-care is actually the new healthcare. So, in conclusion, we should be our own advocate. We should be our own best friend. And so what does a best friend do for you? Our best friend checks in with us. She listens to you. She supports you. She fights for you. She knows you. She trusts you. She loves you. She respects you and she appreciates you. I want to express my gratitude for taking time out of your busy evenings to hear about this important topic and for the invitation to talk to you.
Thanks again. You were incredible, Dr. Wilson-Smith. And so are you, Heidi. Oh my gosh, we learned so much during this session. And I want to thank the National Coalition of 100 Black Women, the Pennsylvania chapter, for hosting us this evening. Thank you so much, Heidi, for sharing your story. Dr. Robin Wilson-Smith. Visit blackhealthmatters.com, sign up for our newsletter, and you'll be able to find out about programs that we have. Thank you and good night, everyone. Have a wonderful evening.